Welcome to Spine Guy. I'm Dr. Brian Sue, a fellowship-trained spine surgeon. The Spine Guy is a channel dedicated to making the complex spine simple for patients to understand. Today we'll be talking about non-surgical management of lumbar foraminal stenosis. As a reminder, foraminal stenosis is pinching of the nerves as they exit the spine. So just because there's significant nerve compression doesn't mean it has to be treated. Sometimes these are incidental findings, meaning we see them on the MRI that get pointed out. But if you're not really having a ton of buttock and leg pain that's affecting your quality of life, you don't really have to do anything for it. It's not a problem to have foraminal compression. However, sometimes what can happen is that nerve can get compressed, irritated, swollen, and there's a cycle of inflammation where the nerve is pissed off and it keeps getting irritated, and so you get persistent buttock and leg pain as a result of it. So there's two different ways to treat a pinched nerve. The first is to take the inflammation off the nerve so that the nerve can learn to live in a small space. The other is surgery, where you can create room for the nerve. For foraminal stenosis, we always try non-surgical management for the first 6 to 12 weeks for sure, because most patients with foraminal stenosis do get better with non-surgical means. So one way to create a little bit of temporary room is to do an inversion table, weight loss, as well as physical therapy to help strengthen the muscles and take some load off the spine so that that nerve is not so compressed. Next, you can use medications to try to break that cycle of inflammation. There's 4 different categories of medication. The first is Tylenol, which can be a fairly effective pain reliever, although not as good as anti-inflammatories. If you're going to take Tylenol, be careful. You can overdose on Tylenol. You don't want to take more than 4 grams of Tylenol a day. The next category of drugs is anti-inflammatories, or NSAIDs, so non-steroidal anti-inflammatory medicines. Very common ones are Motrin or Aleve. So Motrin is the same as ibuprofen, and Aleve is the same as naproxen. I typically tell patients to take Motrin. I think the mistake that patients make is when they first get leg pain, they only take the medication when there's pain, and then once there's no pain, they stop taking it. So really, for an anti-inflammatory to be effective, you have to take it around the clock like an antibiotic, so it builds a baseline level of anti-inflammatory in your blood so you can break the cycle of inflammation. So I would typically recommend, depending on your size, ibuprofen 600 to 800 3 times a day for 10 days straight like an antibiotic. After that, I wouldn't take it for longer than that, and of course you should always do this under the direction of your doctor. The next class of medications is narcotics. Narcotics, as a warning, they are addictive medicines, and they really just dull your body's sensation to pain. There's lots of different types of narcotics, ranging from tramadol, which is the lightest, going up to Norco. Norco is the same as hydrocodone plus Tylenol. Then there's oxycodone, and then there's Percocet, which is oxycodone plus Tylenol. Just as an aside, for those medications that contain Tylenol, like Percocet, like Norco, you don't want to take Norco and Percocet along with Tylenol on top of it, because you can actually overdose on the Tylenol component. There are nerve medications that can be quite effective. These nerve medications decrease your body's ability of the nerves to transmit pain signals. The most common nerve medicine is called Neurontin, which is the same as gabapentin. These medications, in my experience, 25% of patients can get some side effects. It can make you sleepy, a little bit cloudy, foggy, goofy, etc. I usually tell patients to start Neurontin on a low dose, 200 milligrams twice a day. And if you can tolerate it, then to double and triple it up to 600 milligrams twice a day. And you can even go higher than that if you like, under the direction of your doctor. For patients that do get some side effects to Neurontin, but it is effective, you can consider using Lyrica, which is a very similar drug or derivative of Neurontin. It's called pregabalin, whereas Neurontin's gabapentin. Lyrica is sometimes not covered by insurance because it can be expensive, so you often have to document that you failed Neurontin. Again, you would work with your doctor to do this. One of the most effective ways to treat a pinched nerve and take the inflammation off the nerve is something called an epidural steroid injection, or a selective nerve injection. This involves an anesthesia pain doctor or a physiatrist or an interventional radiologist taking a needle and under x-ray guidance target that nerve that's a problem and target that nerve that's inflamed to drip a little steroid over the nerve to really get the maximum amount of anti-inflammatory over that nerve. I have a great video on what happens during a lumbar epidural steroid injection on my YouTube channel. These injections can be diagnostic and therapeutic. Therapeutic in the sense that it can take the inflammation off the nerve and break the cycle of inflammation, and maybe that's all you need. It's diagnostic in the sense that in many patients we'll see multi-level foraminal stenosis, meaning lots of different levels are involved. But if we do a selective nerve root injection over one particular area and it takes your buttock and leg pain away for a couple of days or for weeks, then we know that that particular nerve is the problem. Sometimes if we're really not sure and we're trying to figure out specifically where to do a targeted strike, particularly with surgery, we'll do something called a diagnostic nerve block, low volume anesthetic without steroid. When you put steroids even around the nerve, some of that steroid gets absorbed into the bloodstream, and what can happen is everything can feel better. Even if you have a sore elbow, to make it feel better if you put steroid in your back. So a diagnostic nerve block is done low volume, specifically only one specific nerve. For example, the L4 nerve, diagnostic block, meaning they would take a needle and just numb the L4 nerve, use a very low volume so that it doesn't spread anywhere, and there's no steroid in it, so we don't expect the effect to be long lasting. However, if you do get temporary relief, even for a few hours, then we know that the L4 nerve is the problem and that we have to address the L4-L5 foramen. In terms of frequency of injections, I usually let patients get 2 injections separated by 6 weeks. After that, if it's not working, then you either learn to live with the pain, or you can certainly have the foraminal stenosis surgically treated. But I would not recommend injection after injection, particularly if they're only helping temporarily. Another way to introduce steroids over the nerve is by taking oral prednisone or steroid tablets. In my mind, taking oral prednisone is not quite as good as doing an injection, because the injection gets all of the steroid concentrated over exactly where the problem is. When you're taking oral steroids, the steroids go everywhere in the body, which means that they can have side effects. Oral steroids can cause elevated blood sugar, it can cause sleeplessness, it can cause mania. In fact, that's where the term roid rage comes from. If you're going to get oral steroids, your doctor's most likely going to prescribe it in a tapering dose. How I prescribe it is prednisone, 60 milligrams times 1 day, and then 50, 40, 30, 20, 10, which is a 6-day taper dose. It's important to always taper steroids when you're taking it. Because of the side effects, I would definitely do it under the direction of your doctor. So hopefully you learned something about foraminal stenosis, what it is, and how to treat it non-surgically. In our next video, we'll talk about surgical treatments of lumbar foraminal stenosis. Thanks for watching. Don't forget to click the like and subscribe button.